Assalamu alaikum. First of all, I would like to thank you, Prof. Ali Madawi, for inviting me, and of course, thank you to Egyptian Spine Association for being part of this great conference for the last 5 years. Today, I'll be presenting about the active apex correction for early onset scoliosis. I've done about like 17 cases in the last year. I started in October or November 2023, and now it's a year, 1 year since I started this technique, and I've done 17 cases. I'll start my presentation with a case or a few cases. So this is a 3-year-old girl, healthy. She has idiopathic scoliosis, cup angle about 60 degrees, failed all non-operative treatment, and her weight is 13 kilo. This is her X-ray. This is AP and lateral. If we have so many options: traditional growing rod, magic rod, Sheila method, Vipter, anterior stapling, tethering now, modern locket trolley, or active apex correction. So we have like 8 options we can offer this patient, but each option has its pros and cons, and of course, always the options goes back to the surgeon and what he's comfortable with. Second case, a 5-year-old boy, healthy, idiopathic cup angle of 70 degrees, curve is progressing, and his weight is 16 kilo. When I see such cases, I always I don't get CT scan in all cases, but when I see such sharp curve, I have to get a CT scan just to make sure there is no evidence of any congenital anomaly. So again, traditional growing rod, magic rod, Sheila, Vipter, tethering, stapling, modern locket trolley, ABC. If I start talking about each of this option, I need at least an hour, and I put those there, so it's all they're right, not wrong. But as I said, like some of them better than the others, and again, at the end, it's depend on the surgeon itself. Case 3, 6-year-old boy, healthy, idiopathic scoliosis, cup angle 70, and weight is 13 kilogram. I'm emphasizing on the weight, and I will keep presenting the weight in each cases, because the weight, it does matter in those cases. Because if you're planning to use a magic rod in a 13 kilo boy, he will walk with the magic rod is prominent in his back. So I always, when I get these cases, I used to think what is the best implant for those cases. Again, this is a very sharp case. When you look at it, you say, oh, I'm sure it's congenital. You get the CT scan and you don't see any congenital anomaly. Again, same options, nothing wrong with those all options, but some of them, they're not in the market anymore, or nobody is using it as before, like Vipter. Case 4, 6-year-old, healthy, idiopathic, cup angle 60 degree, and weight is 14 kilo. Again, similar options. So what's in ABC? I'm not going to go into details, because I think the next talk is about the technique as well. It's a hybrid combination of 2 concepts, guided growth and compression. So this combination will achieve correction without affecting spinal growth. Guided growth technique is more familiar to the orthopedic surgeon more than neurosurgeon, because we do that in not only in the spine, we do that in limb lengthening and limb deformity correction. The idea is just to stop the growth from one side so the other side grows and it corrects the deformity. So the difference between the ABC technique is closer to the Sheila technique, but we all know that the Sheila technique depend on the correction at the apex. So the apex is always where they do the correction, and the gliding of the growing rod, it happens in the proximal and distal foundation. The ABC technique, you do correction at the apex, but also the gliding, it happens at the periphery. But the difference between those, I always tell my resident, whatever you do for growing road construct, the success always depends on the technique. While you're sliding the road or the connector on the part of the spine that you did not dissect, if the rod touches the bone, then there will be some fusion. So always is the technique, is how to pass the rod or the connector under that part that you did not dissect without touching the bone. If that rod touched the bone, it's finished. There will be some fusion at the end. So what you need for ABC, to start with, you need idiopathic scoliosis. I've done a few syndromic cases. I haven't done any congenital yet, but I have some congenital cases in my list, and I'm going to do them maybe next year, inshallah. I'll present them. You always look for a single curve. You cannot do a double curve. You have to be careful about the kyphosis, although you can correct the kyphosis with the ABC technique, but it's something that still under discussion. Of course, because those young patients, you have to use the small size system 4.5. You have to have dominers or connectors, neuromonitoring always, careful X-ray assessment and CT assessment and planning if needed. Choosing the correct level and double checking about the correct level intraoperatively, because things can change. This is my first case, and this is the master planning or preoperative planning was done by handwriting by Dr. Ala Azmi, and we all know that he's the one who was behind this new technique. Always, this is my drawing, and so I can share it with my team intraoperatively. So we'll be all on the same page. I have to choose the most wedge vertebra so I can put my screw top and bottoms for the compression. I think next talk about the technique. You can, of course, always must be 2 incision, proximal and distal for the foundation, and minimal dissection where you put your screws for the compression. Sometimes you can just end up with 2 incisions, because as you see in this one, the proximal foundation is very close to the wedge vertebra, so I didn't have to do a 3rd incision. I just had to extend my incision a little bit. And of course, where I do my most wedge above and below screws, I do minimal dissection, like almost Wells technique, just muscle spreading. This is the first case. This is the 1 month post-op X-ray. This is the second case. One of the things that I found with ABC technique that you get maximum or a lot of correction immediately post-operatively, like on the spot you get a lot of correction, as you can see in these cases. As you can see, I got tremendous amount of correction just by applying this technique. If someone look at this, he think it's kyphotic, but it's not. It's just rotational deformity. Of course, always this is my wedge vertebra. I go 1 above and 1 below for the compression, for the epiphysiodesis. This is the data for my 17 cases. The last case I've done this month, in November 4th. And as you can see in the data, most of them, I've done actually one of the cases neuromuscular, I forgot about that, but mostly are the idiopathic one. Complication that may happen, if you look carefully at this X-ray, you can see on the lateral X-ray that the rod is not in line with the rest of the rod, and if you look at the AP, You can see some, if you look at this side, you can see that the screw part is not as obvious as here. So that's mean there's something going on here. It's you have to be very careful when you connecting those dominoes, because the rod unfortunately dislodged from the connector in this case. This is another complex case. We've done, as you can see, excellent correction. In these cases, I always cast them before they go home, because I know that children, once their pain is relieved, they're up and down, and this is what can happen. This patient particularly was in ICU for about 1 week because of respiratory issues. As you can see, she's post-cardiac disease, and she has some devices for the heart. My resident discharged her home without casting her, which is the usual plan, and she comes to my clinic in 2 weeks with proximal foundation screws out. So she's for revision. So my tips or my recommendation from those 17 cases: careful pre-op X-ray assessment and draw your plan. Make sure that you have a good assistant. Careful intraoperative level targeting by fluoro. Make sure not to put bone graft at the apex and minimally dissection at the apex. Connect your domino before you slide the rod under the muscle. Cast your patient before discharge home. Thank you.